welcome to our lunch symposium, and good morning from America, where this is a breakfast symposium. We're going to be discussing the highest quality of care and complex EVAR procedures with advanced imaging techniques from planning to follow-up. Thank you to Philips for sponsoring this excellent session. And we have three excellent panelists who are going to be speaking to us today. First up will be Dr. Kak Khee Yeung from Amsterdam, who will be discussing improving EVAR outcome from planning to live using new generation of Azurion Platform. After that, we'll have Professor Henrik Sillesen from Copenhagen, who will be discussing improving AAA measurement accuracy using Innovative Ultrasound 3D volume model automation in xMATRIX. And then we'll have Dr. Jörg Tessarek from LINC, who will be discussing new generation mobile C-arms. Do they meet the needs for safe and reliable EVAR? I'm looking forward to all three, and so we'll kick things off with Dr. Yeung.
Thank you, Chairman, ladies and gentlemen. Improving EVAR outcome from planning to live using new generation of Azurion Platform. These are my disclosures. This is an image of our team in our hybrid room. Today, I'm going to talk to you about how we can optimally use our hybrid room from using actually the new generation of Azurion Platform, from procedure planning to the procedure itself, but also the final check, providing a complete EVAR workflow, even suitable for complex EVAR repair. Now here you can see all the tools that are integrated in our hybrid room. Today I will focus on the EVA on screen and a smart CT. As you know, there's a vessel navigator. That's an overlay that's possible from your CT scan on your live X-ray. But in the new Azurion Platform, there's also a marker tool. And on your iPad screen, with an easy hand gesture, you can draw lines for your landing zone, or make an outer line where you have to place your stent graft. But also quick measurements are possible of your diameter or length of the stent graft that you need. Another new option is also the full APC. That means that you can recall your previous position of your angiography, and all these positions are actually stored. We have an ultrasound integration in the Azurion Platform, and also dose aware, so you know how much radiation you catch actually during the procedure. So today we focus on the EVA and the smart CT, and I will do that by example. I want to present to you a case where the Azurion Platform helps us from planning to follow up. This case involves a female patient of 70 years, a previous smoker, and she received in 2017 a BVAR procedure, a full-branched, because of a COVID type 2 thoracoabdominal aortic repair, aneurysm of 69 millimeters. The problem is actually now that she has a type 3 endoleak and disconnection of an SMA stent graft. Here you can see the type 3 endoleak in the aneurysm. And this is my desk and my technical physician, Stefan Smorenburg. And here we plan our procedure with EVA. So our plan is to reline the SMA with the Viabahn BX 8 mm from femoral axis. On the left side, you see the new photorealistic volume rendering, where the endoleak is presented in red. And on the right side, you can see the disconnection of the SMA graft with the branch. So this is our screen that we see on my desk. And this is the branch, and this is the SMA, stent graft in the SMA, and this is disconnected. So what we want is actually to reline this graft, the branch again with the SMA. And this is very easy with the EVA. Because there's a possibility that you just click on where the central luminal should be, and an automatic central luminal line will be provided by EVA, and also the length that we need for the minimal overlap of 40 millimeters and 65 millimeters for maximal overlap. you have this view in 3D, but also in other views. So this AVA planning can be recalled during our procedure on the hybrid room. So this is our hybrid room again, and this is me, and this is my colleague vascular surgeon Vincent Jonkind, and the team of anesthesiology at the head of the patient. So we first want to fuse our images using the vessel navigator by 2D registration with 2 fluoroscopic images, and we fuse it on the pelvic bone. And this is the autofade option to check if we are well fused the images. And then after the fusion, the live guidance is ready. Then we puncture the femoral artery by the integrated ultrasound. And like I said, we can easily recall the AVA on the table side. And on my left side is the intervention radiologist. And I decided actually to change my vessel navigator visualization to an outline visualization only, because then you can see the live X-ray on your outline together. And the orifices, actually from the SMA and the branch, are given in blue rings. And it's just, we advance the wire through these blue rings into the SMA. And once we advance the terumo wire, we change the terumo wire with a stiff wire, the Amplatz wire, and we use the steerable sheet for it as well. So after that, we checked again our measurements made on AVA, and we placed the Viabahn BX, and we deployed it by ballooning. And note that there is a dose-aware integration on the left side and vital parameters of the patient on the right side, and AVA is visible in the middle. After deployment of the stent graft, we performed the final DSH just to check if the realignment was fine. And we achieved good realignment, and there were no complications. So then we performed the smart CT and CBCT dual acquisition to check the procedure outcome. First round is an arterial phase round. And after 7 or 15 seconds, you can decide to perform a venous round. And that's a venous phase, I mean. And then we check the outcome from the smart CT viewing at our table site. And there was no endoleak seen anymore, and a great realignment as well. So we were very happy with our procedure, of course. So the advantages of the planning with AVA is that it's easy to use. There's a fully automated segmentation, vessel center lines, like even when it's disconnected, like the SMA graft, there is an automatic center luminal line and automatic luminal wall contours, and also a possibility for stent site selection. You can plan it everywhere from your desk top, and you can bring it into your hybrid room. It's fully integrated with Azurion. So here, again, you can recall your AVA planning on your hybrid room and easily check your measurements that you have made before on your desktop. So we used also the smart CT directly post-operatively for evaluation of the procedure. Was there any kinking or endoleaks in arterial and late venous phase? You can evaluate the type 1 or the type 2 endoleaks. And there's no need for the patient to return soon on short term for a CTA. So you can view your smart CT that you have made on your table side, but there is also an option for a 3D view, and you can evaluate your stent graft realignment and if there are any kinking of the stent graft and how the overlap was. There are 2 phases, like I said before, an arterial phase and a venous phase that we have performed. There was no endoleak and a very good realignment of our case. And there's an option to actually show the contrast in red color, like blood, to visualize even better the endoleaks and the perfusion of the organs. And there is also an option to view it in another view, like the corner view. Now I have showed you how you use the Smart CT post-operatively, and most of our vascular surgeons use actually the Smart CT post-operatively, but you can also use the Smart CT platform pre-operatively. When during the procedure, unexpected access problems occur, so like you cannot advance your wire and you want to know what's happening, you can make a Smart CT on your hybrid room during your procedure to detect problems, but you can also plan it because you want to use a Smart CT for live guidance, because a CT that you have made with the patient breathing and in another room is different always than a CT made on your table side. So you can also use a Smart CT for live guidance and live measurements on the hybrid room. So that's what I want to show you here, an example of an occluded right common iliac artery and stenosis on the left side. We performed a pre-operative CT, Smart CT, actually on the table side. And this is the 3D image that you then get. And this is actually what we used for live guidance. So this is how it looks like. We can navigate on the Smart CT. So on the left side, you have the live X-ray, and on the right side, the fused live X-ray with your Smart CT. And this is, again, the image of your 3D CT. And you can see the occlusion here that we have to recanalize. And here are the stenosis of the left side. What's also possible is not only guidance during your procedure, but also determine your diameter of your stent graft needed with the Smart CT that you have made on your table side. There's an automatic segmentation, and here's a stretched vessel, and you can move it to determine your diameters needed for your stent graft. And these are the views in an axial view as well. So at the end of the procedure, you can see that we have performed a kissing procedure, and this is the live Smart CT and the live X-ray fused together. So let me summarize how we can use the Smart CT platform. You can plan the CT on the hybrid room, also for specific branch cases, like if you have a EVAR procedure that you perform staged and you have left one branch open, you want to see if this branch is still open or is anything happened with that branch, because sometimes it gets occluded in your waiting time. You can decide to perform a Smart CT on the hybrid room so the patient doesn't have to come back to perform an earlier CTA to evaluate the procedure before. You can use a Smart CT to identify or detect endoleaks on the hybrid room. And you can use the Smart CT roadmap to treat the endoleaks or reline the branch. We know that we can use the Smart CT for control after procedure of complex vascular procedures. And the advantages is that you can evaluate it directly after the procedure so the patient doesn't have to come back for a CTA. So all these tools of the Azurion platform leads to a better visualization and an accurate planning, navigation, and confirmation. And all these things lead to better clinical decision making. It has a very intuitive workflow, and also reduce contrast and radiation, providing a better staff and patient safety. It's very easy to use. There are iPads, you can work with a mouse on the screen, and you can focus totally on your procedure and your patient, and all these things will reduce complications. So thank you for listening. I'm happy to take any questions.
Hello. My name is Henrik Sillesen from Copenhagen, and I'm very happy to be here at LINC, speaking about improving AAA measurement accuracy using innovative ultrasound 3D volume model, automation, and xMATRIX. Now, matrix transducer technology involves using multiple parallel arrays of ultrasound crystals. And currently there's two models available, and I'm just speaking about the one on the left, the X61, which is ideal for ultrasound examination of aortic aneurysms. And the 3D transducer works in two ways. We can do live imaging in two planes, as you see on the left, the so-called X-plane or dual plane. If you look below, on the left, you will see an aortic aneurysm in transverse and in longitudinal scanning. And apart from that, we can also do a full 3D volume acquisition and then have a segmentation of the aneurysm, and then this model built, which shows the center line, and it also identifies the maximum diameter according to the center line. So what kind of accuracy of ultrasound scans is needed? Well, for AAA diagnosis, the size is important. So we need to know accurately how big the aneurysm is, so we can compare that with our recommendations for treatment. And typically that is, we need something that is accurate in respect to what we see on a CT. Now for surveillance, being it virgin aneurysms or after EVAR procedures, it's different. There we need reproducibility. Has the size changed since the last scan? Probably also being an ultrasound scan. So let's look at 3D ultrasound for native aneurysms. We did this work a few years ago where we looked at 54 patients with native aneurysms that were scanned both with 3D ultrasound and CT within 2 weeks. We compared the accuracy of diameter measurement using the X-plane or dual plane method, as I showed you, and also using the 3D acquisition with segmentation, both compared to diameter acquired by 3D CT. We also had 79 patients that were scanned by two independent ultrasound sonographers, unaware of each other's results, so we could look at reproducibility. First, the results of diameter compared to CT. To the left, we are using the dual plane to measure the diameter. Notice that we have a mean bias of 2.6 millimeters, so we are measuring 2.6 millimeters smaller than on CT. But the average variability or limit of agreement is plus minus 3.3, quite nice compared to the usual plus minus 5 millimeter we usually talk about on 2D. If you go to the left, you see we have used the full volume acquisition, and here we see a slightly smaller mean difference of 1.8 and a variability of plus minus 3 millimeter. So again, very nice results compared to the usual 2D. If we look at the reproducibility of two independent investigators, we have no bias, so the average size was the same, irrespective of if we did the X-plane dual plane imaging method or the full volume acquisition. And again, notice that the variability is plus minus 3.6 for the dual plane and plus minus 3.2 for the full volume acquisition. So very nice results, seemingly better than 2D. So this study concluded that 3D ultrasound is accurate for assessment of native aneurysms as compared to CT, and it's also very reproducible. However, this study was performed by two experienced researchers who have worked for years with 3D ultrasound. How would this look if we took it into daily practice? So we went to Cincinnati into Shashi Kilaru's lab, where we found two very experienced registered vascular technicians who had never worked with 3D ultrasound. And they had a half-a-day course in using the 3D ultrasound, how to acquire data and how to measure it. And then they scanned 90 patients blinded from each other's results. They did 2D using the classic curved array C51, and then they did 3D ultrasound with the X61, as I just showed you. They measured the largest AP diameter on the 2D images, and then they acquired a 3D data set to be measured later. Here you see the Bland and Altman plots for the two methods. To the left, you see inter-operator variability on 3D ultrasound. So we compare the two sonographers' 3D scan on A, and to the right on B, we do the same thing using the 2D. You can clearly see that the limits of agreement, the dotted lines, are much more narrow on A than on B. And if you look at the red box below, you can see that the variability was plus minus 3.1 millimeter on 3D and plus minus 4.8, as we would expect on 2D. And in fact, looking at the statistics, if we look at the confidence intervals for the limits of agreement, they do not overlap. So there's actually statistically significant, more accurate or better reproducibility of 3D compared to 2D. What about 3D ultrasound for EVAR surveillance? This is actually where we began using this technique even before the transducer was released. So you see this goes 7 years back, this work. And here you see some early slides. Slide A, image A and C are ultrasound slides of post-EVAR sacs, which you can see the graft inside, and you see the corresponding CTs. And here we looked at the diameter measurements on 3D ultrasound and on CT, and also did similar measurements, 3D CT compared to 2D ultrasound. So the left graph A is the 3D. You notice that there's a small bias, only 1.3, but a high availability of plus minus 6.5. If you go to the right and see the 2D compared with 3D CT, the variability is even greater, plus minus 9.4 millimeter when compared to CT. And there's obviously many reasons why this is seemingly worse than when we do native aneurysms. And of course, because this is the shape of the aneurysm sac that becomes irregular. There's a metal skeleton of the graft that makes artifacts. And there's all kind of reasons that this is more difficult. But again, this is compared to CT. And remember, what are we doing when we are having surveillance after? We are comparing to the scan of the last visit. So reproducibility is more important. Here you see the reproducibility of 3D ultrasound on post-EVAR sacs. And you can see to the left the inter-operator, so two different investigators, to the right the same operators in scanning the same patients. And now the variability is plus minus 4.4 or plus minus 3.9. So certainly now within a very reasonable limit of agreement. So we can say that accuracy of estimation of post-EVAR AAA sac diameter is more challenging than that of native aneurysms, but 3D ultrasound is more accurate than 2D, and the intra-operator variability is within reasonable limits. Now, recently, all of this work has come on the scanner as an app. So let me show how it works live.
So when we want to scan to look for an abdominal aortic aneurysm, we choose the X61 transducer, which you see in my hand right here. I activate the X-plane function. So the screen now is divided into two. And then I identify the abdominal aorta, as you see right here. So on the left side, you see in the longitudinal, and on the right side in cross section. When I'm happy with the image, I ask the patient to stop breathing. And then I activate the 3D acquisition. Which has now taken place. I then press the AAA button on the scanner, so the system automatically segments the aorta and look for the aneurysm, which is done in a few seconds. Obviously here we have a normal model with a normal aorta, so it does not find something meaningful. But if I'm happy with the findings, I press accept, and then on the top right side you see the relevant diameters, the AP, the lateral, and the maximum diameter.
So with the app on the scanner, it's really become much easier. Notice on the bottom part of this image, you can see there is a black box called Q apps, and there is a button you can press that says AAA. And on the top, you see we just did a 3D acquisition of a virgin aneurysm with a big thrombus. And I then press the AAA button, and the system automatically makes this segmentation. Just as you saw before, it takes somewhere between 20 and 40 seconds. If you think this looks fine, and I think this is fine, I press the button again, and then I get the diameters, I get the AP, I get the lateral, and I get the maximum. And you can, if you look at the image on top with the round lines, and you see this, you see the center line. You can notice this green diameter line, and that's the max diameter. And I got an EVAR case here, which we see here, and we do the segmentation, and we think it looks fine, and we get the diameter measurements automatically, all within 1 minute. So in conclusion, 3D ultrasound is accurate for assessment of maximum diameter in virgin AAA and post-EVAR cases. 3D ultrasound is superior to 2D ultrasound for assessment of AAA and post-EVAR diameter. 3D ultrasound can also access AAA volume, which is possibly a more sensitive parameter to follow than AAA diameter, although we don't really have any useful data yet. 3D ultrasound is easy to learn and work with, and 3D analysis segmentation is now very easy with the app OnCard. Thank you very much for your attention.
Okay, so that's fine. So, dear Chairman, ladies and gentlemen, dear colleagues, thank you for giving me the opportunity to talk about this very interesting topic. Although it seems to be a bit of an anachronism to talk about mobile systems, while in most of the operative settings, fixed systems are available. But we are talking about systems from 2020 with software solutions from 2021 and a lot of additional technical options to integrate adjunctive image guiding techniques, just like IVUS. At the end of the day, with these compact and complex systems, it's a question of must-have or nice-to-have. And I think both planes will reach their final destination. The question is at what ticket price and at what fuel consumption. Fortunately, we do have the Allura Clarity, the A380, with all software solutions at hand, just like post-processing software Clarity for radiation reduction and 3D imaging. Fusion, we have a comfortable room size of 72 square meters that allows everybody to walk around the yellow radiation control area, so it allows an optimal workflow. And with the setting, we can do any kind of endovascular procedure, just like vascular trauma or complex aortic procedures with a variety of exercise, radial and brachial approach, but also pedal approaches and retrograde recanalization. The question is, if we downsize the portfolio to standard EVAR and to standard aorto-iliac procedures, wouldn't it be sufficient to have a mobile system like the Sillesen in this setting? Fortunately, we do have this setting as well. With all the protection shields in place, we have a mobile table that can be moved in both directions, but also rotated to optimize the patient position for carbon dioxide angiography. And the system has high resolution screens, integrated IVUS, all image processing options. So we have the software solutions. We have still a comfortable room size here to let people walk around the yellow radiation control area. And this, again, allows an optimal workflow with all logistics in place. The question is, can we rely on this downsized solution the same way as the other? Well, we ask 13 vascular surgeons and 3 students to evaluate fluoroscopic images from the Sillesen and angioruns from the Sillesen with images from different origin. And it was interesting to see that besides the individual preference for the grayscale in image brightness as best or different resolution in angiographic imaging as best, there was obviously no difference in image quality between the different sources. One thing that has to be highlighted is the integration of IVUS, because we have been doing IVUS guided EVAR with the Allura for a long time. And in 55 completely IVUS guided procedures with fluoroscopy only, we could see there is no use of contrast. There is a significant reduction of radiation dose and of scattered radiation. So this is a benefit for the procedural quality. And in terms of reliability, IVUS is better to identify intimal flaps in dissections, but also in PAD procedures to be sure that the wall opposition of graft and stent is accurate and that there is no infolding, crimping, residual stenosis in grafts and stents, or that there is no incomplete plaque coverage, and all this without radiation, just by a single run through of the IVUS catheter. There is sufficient evidence that IVUS in combination with fluoroscopy only has better immediate and long-term outcomes for EVAR, but also for PAD procedures. The difference now between mobile C-arm with angiographic guidance and mobile C-arm with IVUS guidance is also significant. We have a 73% reduction of the dose area product, but there is a bit of a bias because these here are different operators, and this here is a single operator outcome. But in this situation, there are no oblique projections, there's a steady table and C-arm position, and there is no use of contrast at all. Why is it relevant? Because if you use fluoroscopy with 10 images, you have just an air camera of 0.1. And if you make an angiography in the same setting, you have a 100-fold increase, and with an oblique projection, you have a 240-fold increase of radiation dose. So having a standardized setting, fixed C-arm position, fixed table position, including all radiation safety tools in place, you have an identical workflow. We also use the same endografts, of course, and we use the same vessel access percutaneously under local anesthesia. And in both settings, we can achieve the same procedure time, and we have an identical 30-day and long-term outcome, now comparing 41 aortic procedures done with a mobile C-arm to the standard situation with 100% technical success, no mortality, only one type 2 endoleak, and no growth with a follow-up of 58 months for our EVAR cases. So in conclusion, the question, does the newest generation mobile C-arms meet the needs for EVAR, can be answered with yes. We have satisfactory image quality, we have absolute reliability, and the combination of IVUS and mobile C-arm is absolutely fit for EVAR and endo procedures in the aortoiliac segments at affordable costs and at cost-free reduction of radiation for around 73%. There is no compromising in reliability, safety, and durability for EVAR, for PAD, and for endovenous procedures. So the workflow is not changed, and this is another reason why the answer can only be yes. Thank you.
Well, thank you all. Excellent talks. I think we'll have some people send in some questions, but in the meantime, I have a couple. Dr. Yeung, I'll start with you. Can you tell us the dose and timing for contrast when you do the smart CT?
Thank you for the question, Mark. The dose and timing, so the contrast is about the same as the CTA that you perform actually on if you plan. So that is about around 100 milliliters of doses. But usually I do 50-50, so then it's only 50 milliliters of contrast needed for this run, arterial and venous phase. Yeah.
Great. Yeah, some amazing results that you got there. And so now that you have this smart CT that you can use pre-op, I assume you'll use that sometimes for ruptures or other emergent cases. And I guess my question is, when would you use the smart CT versus the vessel navigator?
So the smart CT has now a limited view. Yeah, so the smart CT now has a limited view. So you cannot have like the iliac and the axis on your CT scan. And usually when people come in with a rupture, I really want to know if I have a real good axis and if there's something, if it's suprarenal or more like in the thoracic even. So I perform a thoracoabdominal scan on our ER. So our emergency room has already a CT scan that's very close by our hybrid room. And it's also integrated then in our vessel navigator. So I use my vessel navigator actually always, except the smart CT I use now. We started just to use it actually now I would prefer to do it for branched cases. So when I have to reline a branch again, or when I have to finish the procedure of a branch case, I perform a smart CT on the table, and then I can only reline one branch. So that is usually what I use for planning, and using the smart CT preoperatively. Yeah.
Great, thank you. Professor Sillesen, it looks like the 3D ultrasound might be easier than 2D. So would this broaden the utility so that those of us who don't have the registered vascular technologist degree can actually use it effectively?
Yeah, you know, it's tempting to think that way. I think that one of the good things about 3D ultrasound is probably it's going to shorten the learning curve. One of the things that we experience is that the very experienced RVT or sonographer, they're used to doing 3D in their brain. Having 3D equipment is kind of like a shortcut. So I think that it will. I think, as we showed quite convincingly, it's going to reduce variability, and it's actually going to speed up things with these automated apps. The only thing that's left is that you still need someone who knows what ultrasound is to see that the acquisition is okay. Because it's just like any data analysis you do. If you get rubbish in, you get rubbish out. So you have to be sure that your acquisition is good. Once you learn to see that, then you get good data out.
And when you compare the 3D ultrasound to the CT, should the CT be the gold standard? And in particular, if it's not done with orthogonal views with a centerline measurements, so which one is the right one?
Yeah, so I mean, for the comparisons here, we did the analysis on the same software. So we would have the CTs in the same software as the ultrasound images. So it was all centerline based when we looked at the 3D acquisitions. And, you know, to be honest, the ultrasound is still a little bit more variable than CT. But I mean, with all the advantages of ultrasound, I think that if we can replace all the surveillance to ultrasound and then use CT when we plan procedures, I think that's a fair way to split it.
Great, thank you. All right, Dr. Tessarek, we have a question from the audience that would like to have you comment on the Philips Zenischen versus the Zeem hybrid model. Any thoughts?
Sorry, I did not understand. What the Zeem hybrid? What? I have. Can you repeat the question, please?
Yeah, it's the Philips Zenischen versus the Zeem, Z-I-E-H-M. I'm not familiar with that hybrid model myself.
No, I don't know this, so I can't give any comment on this. I'm sorry for that.
Sure. Well, I can ask you then, so you have rooms that have the fixed equipment, and then you have other rooms that have the mobile C-arm. And you've shown us that you can do EVARs and straightforward cases. So where do you set the line? What types of cases would you only do with the fixed equipment? Or are there cases that you would only do in the room with the fixed equipment?
Well, if the estimated operating time is long, or if you need several exercises coming from the arm or with an auxiliary approach for branch devices, or if it's highly probable that you need wire to cross a lesion coming from above, then I would use the Allura. But standard EVA means you have an intrarenal EVA procedure because you have made the planning and you know what happens. Then I'm quite confident with the C-arm too, because I can choose which way to go. And if the fixed system is in work, I can use the C-arm. So I don't care about this because I have IVUS. And IVUS gives another option to have excellent imaging, to have all the measurement options Dr. Yeung mentioned. And so we don't have any disadvantaged using one or the other machine for standard EVAR cases.
And it seemed like when you asked the people, the students and the surgeons, what images were better, it seemed like there was quite a bit of variability in the answers. Is image quality subjective?
Yeah, I think it seems to be. So we were just playing a bit with the grayscale, and then somebody said, "Oh no, this looks much better." So it's in the end, I think it's the question: what is the intraoperative image, and what is the option for post-processing, for documentation? What we could see is that with a BMI of 32 to 34, the gap between the fixed system and the mobile C-arm becomes evident. But with a standard BMI, and depending, of course, on the screen quality you have, the resolution is the same, and even for angiographic images, there was no difference noticed by the surgeons or by the students. So it was interesting to see. But in fact, my white and black evaluation is different probably from yours. So imaging quality is a matter of subjective evaluation, partially.
Great, thanks. And then Dr. Yeung, I'll come back to you. With the AVA, it looks amazing. So what types of cases do you tend to use this for? Where do you find it to be the most valuable? Do you use it for all your EVARs, fenestrated branch cases, and for others outside of the aorta? How do you use it?
So the AVA is still in development, actually. So we right now use it for you can use it actually for all cases. So I use it for TVAR cases and for branch and normal normal EVAR cases as well. So you can use it for everything that you want. Actually, it's comparable to other measurements programs like Trimentio or TerraRecon. But the advantage is that you now can have it also back in your hybrid room on your big screen, and that you actually always have the same buttons and the same screen that you're using everything with. So I think that it would be a huge advantage of using the AVA, that it's all in one system in your hybrid room as well. So everything is just the same.
And can you access it remotely from home to do your planning? Working 24 hours a day, or do you have to be there sitting in the room?
No, the AVA you can plan from your desk and everywhere. So if you have it from home, access to your hospital, so I have, then I can just plan it from home, and then you have it in your hybrid room on call. Yeah.
Excellent, excellent. We have time maybe for one last question. Professor Sillesen, you talked about how it's easier now for the technologists. Can you explain what the AAA app is and how that makes things so much easier for everyone?
Yeah, so I think this is one of the first ideas where we kind of changed the idea of an imaging system to, rather than just give you a tool to use for measurements, to give you a tool with an application. So that instead of you have to figure out where to put the calipers and how to make the measurement, the automation does it for you. And although I cannot prove this with data, which I always like to do, I'm going to bet you that the inter-observer variability will be less when you use an automated system rather than a personal measurement system. Perfect. Work is underway.
All right. Thank you all. Thank you to the speakers. Excellent talks from everyone. And thanks to everyone for listening. Take care.
Thank you. Goodbye.